right, so my clinical pattern was on Osgood Schlatter disease, or OSD, which is a growth-related apophysitis of the knee, common in adolescents. Patient demographics, it's most common in boys between the ages of 12 and 15 and girls between the ages of 8 and 12. It is more common in males than females, but that gap actually appears to be closing due to more adolescent female involvement in athletics. Outcome tool, what I saw used most was the knee injury and osteoarthritis outcome score. Mechanism of injury, high forces from the patellar tendon acting on its attachment during maturation where the growth plate is not yet closed, and then repetitive mechanical strain by the quadriceps femoris muscle. Behavior aggravating is activities that load that quadriceps muscle, such as jumping, landing, or running. Easing is rest and NSAIDs. And then the 24-hour pattern, there is pain present at the tibial tuberosity, but usually only after physical activity. It can progress, though, to more permanent and steady pain regardless of activity. I don't believe there's really any need for a systems review or review of systems if you have an adolescent patient presenting with OSD. No research indicates that there are tests that you can't perform, so no precautions or contraindications on a client presenting with OSD, but just that activity and sport modification are important and should be made in order to allow for proper healing. The physical examination, active movement testing, possible reproduction of pain with extension of the knee, more likely though to occur in severe cases and probably wouldn't be any pain with a milder case. Possible reproduction of pain with kneeling position or flexion of the leg. Passive movement testing should be full passive range of motion, possible pain reproduction with the end range knee flexion, especially in a more severe case. Resisted testing, strong and painful knee extension contractile unit test could be weak and painful in a severe case, and then you should have strong and painless knee flexion contractile unit test. You probably do want to assess the patellar mobility, but the findings can be pretty variable with that. Neurodynamics is pretty not applicable in this case. Palpation and increased bony protuberance at the tibial tuberosity, and definitely could be tenderness directly over that area and some local swelling. Special tests, quadriceps tightness is pretty common with this. So an ELI's test with a sensitivity of 56 to 59% and a specificity of 64 to 85% could be used to assess for that quadriceps tightness. Differential diagnosis, there's a couple different things. So like a fracture of the tibial tuberosity, that though usually has a history of trauma and the onset is sudden, which isn't really the case with OSD. Sinding-Larsen-Johansson syndrome, that the tibial tuberosity would be normal on an x-ray and the maximal tenderness is at the inferior pole of the patella. Osteochondritis dissecans of the knee, the tenderness is usually localized to the joint line and not at the tibial tuberosity, and that lesion would be apparent on an x-ray. Hoffa's disease, the tenderness is anterior joint line, lateral to the patellar tendon, and an x-ray would be normal. Infrapatellar bursitis, it did say that that could be difficult to differentiate, but there might not be any tenderness at the tibial tuberosity, and an x-ray would be normal, but MRI would show that fluid collection in the infrapatellar region. Diagnostic imaging, it's not really common to do this with OSD, but if you do want to do it, a conventional radiograph, I think, would be your first choice to go with. It can show an irregularity of the apophysis with separation from the tibial tuberosity in the early stages and maybe fragmentation in the later stages. You can also use MRI and ultrasonography, and you can read a little bit more about that in the written template. Signs and symptoms indicating referral to the physician. If there's severe and persisting pain even after skeletal maturity, like once that growth plate is closed, and then if there's ossical pain on kneeling, if that persists despite conservative treatments. And that is because both of those could indicate surgery, which leads me to surgical indicators. Like I said, both of those definitely indicators for surgery. What I saw is that if a child is still growing, surgery seems to offer no better benefits. That's why it's best to wait until after that skeletal maturity. And if their symptoms have not resolved, then you might want to look at surgery. Options, there's open procedures such as drilling of the tibial tubercle, there's excision of the tibial tubercle, tibial sequestrectomy, bone peg insertion, and then there's also arthroscopic procedures or bursoscopic procedures. So yeah, that concludes my presentation on OSD.